Hi, everybody. My name is Liz Utaro, and I am one of the emergency medicine pharmacists at the University of Rochester in New York, and I will be moderating today's webinar session. So we just wanted to thank you for joining us today for our Heart-Stopping Pearls, Secrets to Smarter Resuscitation, and we are very happy everybody was able to join. Earlier today, you received an email that included a link to the website where you may review information about the webinar, including the CPE credit, learning objectives, disclosures, and other details. Please note that only members in good standing of AMP who attend this live webinar today can claim CPE credit upon completion of the program. The deadline to complete the evaluation and claim your CPE credit will be Friday, October 31st. The webinar is going to be recorded, and that will be posted on the webinar page of SAEM website for future viewing. Throughout the session, please post any questions you have for the presenters in the Zoom chat, and there will be time at the end of the presentation for questions and answers. If you have any technical issues, please let us know via the chat, and SAEM staff will be happy to assist. To minimize any distractions, please turn off your audio and keep it on mute unless you are speaking. Again, thank you so much for joining our webinar today, and we can go ahead and get started.
All right, so hi everyone. My name is Tina. I'm an ER pharmacist at Methodist Dallas in Texas. And then my co-presenter will be Lisa. Do you want to introduce yourself real quick?
Yes, my name is Lisa Hayes. I'm a pharmacist here at Methodist University Hospital in Memphis, Tennessee. So you have a Methodist duo, just Methodist different ones. And I'll be talking about the second half of the presentation. So
Yes, but not to be confused, we are unrelated. All right, let me display the slides. All right, so many thanks to Liz for the introduction and helping us put together this presentation. We have no disclosures, and these are our objectives. We'll go through them throughout the presentation. But for today, I just want to make sure that we know our focus is for adult patients, non-traumatic cardiac arrest, for both in-hospital and out-of-hospital cardiac arrest, and for shockable and non-shockable rhythms. So under our first learning objective, discuss dosing nuances and subtleties of epinephrine dosing in ACLS, including the history of dosing and alternative strategies. So administration of epinephrine has been a cornerstone of cardiac arrest resuscitation for many decades. Since 1974, AHA has published ACLS guidelines on cardiac arrest. Many adrenergic and antiarrhythmic medications have come and gone, but epinephrine remains the only drug that continues to be recommended for all non-traumatic cardiac arrest. You can see epinephrine here in both the AHA and the ERC guidelines at a dose of 1 milligram every 3 to 5 minutes, and to administer as soon as possible for non-shockable rhythms. The recommendations slightly differ for shockable rhythms, with AHA on the left here recommending after initial defibrillation attempts have failed, or as you can see on the algorithm on the right, after 2 shocks. And per ERC, it's after the 3rd shock instead of the 2nd. So we mentioned that many medications have come and gone and epi at states, but what is the utility of epinephrine in cardiac arrest? Epinephrine is a sympathomimetic catecholamine, as we know, with both alpha and beta receptor activity. The benefit potentially stems from the alpha adrenergic activity by increasing coronary and cerebral perfusion, and thus increasing oxygen delivery and potentially helping to increase rates of ROSC. However, there are also potential harms we think that are stemmed from the beta adrenergic activity by increasing both heart rate and contractility, thus increasing cardiac oxygen demand and leading to arrhythmogenicity. Several in the trials in the past have been conducted to assess the utility of epinephrine, with a few notable ones on this slide. So we have the 2011 PACA trial here. It consisted of 601 patients with out-of-hospital cardiac arrest, and they evaluated epinephrine 1 milligram every 4 minutes versus placebo. They found that epinephrine improved ROSC, but had no difference or worse neurological outcomes, and there's also no difference found in survival to hospital discharge. Then we have the 2015 meta-analysis. They looked at both observational and randomized control trial data, and they evaluated the use of pre-hospital epinephrine for out-of-hospital cardiac arrest and found increasing rates of ROSC. But once again, no difference in survival at 1 month or worse neurological outcomes at discharge. And then lastly here, we have the 2018 Paramedic True trial. This was the most robust trial to date. It was a multi-center randomized double-blind placebo-controlled trial. They enrolled just over 8,014 patients with out-of-hospital cardiac arrest, and these patients were either randomized to the epinephrine cohort or the placebo. Overall, the authors found that epinephrine significantly was associated with a higher rate of survival at 30 days versus placebo, with a number needed to treat of 112. However, there was no difference in survival to discharge with a favorable neurological status. So overall, we see that epinephrine likely is associated with increased ROSC, but not survival with favorable neurological outcome. However, guidelines continue to recommend epinephrine 1 milligram every 3 to 5 minutes. So digging into this a little bit deeper, what is the origin of epinephrine 1 milligram every 3 to 5 minutes? So the first study I looked at was all the way back from 1963, when the authors evaluated whether or not epinephrine contributed to restoration of spontaneous circulation in dogs with cardiac standstill or ventricular fibrillation. This study included 110 dogs weighing in between 6.3 to 14 milligrams, and they used 1 milligram of epinephrine dosing in these animals. You can see the equivalent weight-based dosing here on this slide, about 0.07 mg per kg to 0.16 mg per kg, and that will be like important for future discussions when we're translating to human studies. Then from this, throughout the 1960s and 1980s, 1 milligram epinephrine continues to be used, and it wasn't only until 26 years later that there was a rise in human dose studies, with the most notable one in here, or the first one that here is in 1989. This was a small study and consisted about 10 patients, and they looked at epinephrine 1 milligram versus 3 milligram versus 5 milligram. And they found that systolic blood pressure was directly related to the dose of epinephrine. However, note that clinical outcomes were not evaluated. Then in 1991 here, we have an observational single cohort study of 32 patients with refractory cardiac arrest. Patients with refractory cardiac arrest, after being given multiple standard 1 milligram epinephrine doses, were then given a high dose of epinephrine, 0.2 milligrams per kilogram. And that translates to about 14 milligrams for our 70 kilogram patient. The authors found that coronary perfusion pressure, or CPP, which is a good predictor of good outcomes after cardiac arrest, significantly increased when patients were given high dose epi. And so they hypothesized that high dose epinephrine may improve rates of ROSC. Last study here on the slide is this 1993 out-of-hospital cardiac arrest prospective study. They included consecutive patients admitted with cardiac arrest and sought to evaluate if high-dose epinephrine still had an effect. During cardiac arrest, our body's in acute stress. We already have a lot of response. We also already have a lot of catecholamines being released. But the authors did find that despite already very high plasma epinephrine concentrations during cardiac arrest, more epi still elicited biological responses, such as increasing both aorta and coronary perfusion pressures. But does this correlate to clinical outcomes? And many studies have attempted to evaluate throughout the 1990s. So you can see here, there's a table of many studies throughout the 1990s. I'll only cover them briefly, but they looked at comparing high-dose epinephrine, as you can see in the second column here, versus standard-dose epinephrine. See that the high-dose epinephrine, they range between 7 milligrams to 0.2 milligrams per kilogram, 5 milligrams again. And then in the Carvo study, they had a rapid succession of 5 to 10 to 15 milligrams with a total of 30 milligrams, with the last study ending off at 5 milligrams. Throughout these studies, they evaluated both in-hospital cardiac arrest and out-of-hospital cardiac arrest, and it included both shockable and non-shockable rhythms. Overall, there was no benefit of survival or neurological outcomes, and potentially did find associations with high-dose epi and higher rates of resuscitation. This 2014 systematic review and meta-analysis summarized it pretty well. It included 6 randomized trials, and the investigators compared standard dose epinephrine 1 milligram versus high dose 5 to 10 milligrams. With high dose epinephrine, they were associated with higher rates of ROSC and hospital admission, but there was no significant difference in rates of hospital discharge or survival with a favorable neurological outcome. And so this is all similar to kind of our Paramedic 2 trial when they compared epinephrine versus placebo. Instead, it's more epi versus less epi. We see potentially maybe increased risk of ROSC, but potentially not other favorable neurological outcomes. So switching gears a little bit, we looked at the dose. What about the dosing interval? On the 2022, there was a French registry that was performed, and they looked at out-of-hospital cardiac arrest, and they performed a multiple propensity score adjustment. Looking at these patients in the registry, when they compared more than 5 minutes versus standard 3 to 5 minutes, they found no difference overall. When they're looking at less than 3 minutes, they did find an association with decreased survival with good neurological outcomes and decreased survival at 30 days. And lastly, here on the slide, we have the 2023 systematic review and meta-analysis. These authors sought to evaluate the impact of epinephrine interval on resuscitation outcomes during cardiopulmonary arrest. They included any adults who received CPR and compared the standard interval of 3 to 5 minutes to shorter or longer and reported on outcomes. You can see here the primary outcome here in the red box. They looked at favorable neurological outcome. When looking at less than 3 minutes in the top here compared to 3 to 5 milligrams, or in the bottom graph, when looking at interval greater than 5 minutes, versus 3 to 5 milligrams, you can see the overall result crosses 1 and thus was not statistically significantly different. Another secondary outcome that they looked at was survival to hospital discharge. And once again, no difference when they looked at less than 3 minutes compared to standard on the top graph or greater than 5 minutes compared to the standard on the bottom graph, as both of the overall effects cross over that red line there of 1. So for now, we have this momentum. So to continue 3 to 5 minutes. And I would just like to shameless plug out there, for only $4 a month, you can support our campaign for Q4 Minute for the Win. So for now, we're stuck with epinephrine 1 milligram every 3 to 5 minutes, and we must embrace this. This is just a photo of my neighborhood cat and my dog, and this is how I feel about epi. And for now, part of the many codes that I've been a part of, the team just loves to hammer the patients with epinephrine. And this is just a throwback from our ketamines presentation, or our dodgeball game last year. But more, oops, I don't know that sound, but more isn't always better. And so take this dodgeball game as an example of a cautionary tale. And this leads into our second objective. So our second objective, to identify potential harms and situations when harm may result from epinephrine administration. I want to divide up these potential epinephrine harms to during acute resuscitation and then after ROSC is achieved. So first, on this slide, we have potential harms during resuscitation. So patients in cardiac arrest, we know that already have a high level of stress and catecholamines. These high level of catecholamines and with additional epinephrine can lead to increased myocardial oxygen demand, can lower the VF threshold, and can limit the effectiveness of resuscitation efforts such as ECMO and eCPR. Can also lead to impaired cerebral microvascular circulation, as we've seen associated with poor neurological outcome. And then we can also have impaired intestinal microvascular circulation, which is associated with mortality and morbidity. And so these are the potential harms of epinephrine after we achieve ROSC. With increased oxygen demand and lower threshold for arrhythmias, epinephrine can contribute to post-resuscitation myocardial dysfunction, which further leads to a broader category of PRS, or post-resuscitation syndrome. PRS encompasses a myriad components such as anoxic brain injury, arrest-related myocardial dysfunction, systemic ischemic reperfusion response, and persistent precipitating pathology. And there's more details there on this slide. All in all, to sum it up in simple words, it's very bad. And sometimes we have potential therapeutic approaches to help combat each one of these options, such as targeted temperature management, vasopressors, ECMO, or VADs. But we all know that these potential therapeutic approaches are not foolproof, and really their purpose and their aim is to preserve any remaining function. But why not aim to even prevent the initial insult or damage? And if epinephrine is contributing to this, it's something that we need to consider. So what specific situations or scenarios are more prone to epinephrine harm? When I was preparing for this presentation, I was really trying to identify potential specific patient situations where higher dose epi or more epi or just epinephrine in general would be more harmful. I found this pretty difficult based on the available literature, as all the trials are pretty heterogeneous, and it makes it difficult to draw firm conclusions as we don't have our gold standard randomized controlled placebo-blinded trials, which is hard to do in this patient population. So when I was reading, kind of like looking throughout the literature, I was trying to piece it down into versus scenarios. So is epinephrine potentially more harmful in witnessed or unwitnessed cardiac arrest? Does the delay between cardiac arrest and the first dose of epinephrine administered affect the risk of harm from epinephrine? What about in-hospital versus out-of-hospital cardiac arrest? For this, most of our literature is from our out-of-hospital cardiac arrest, but I know that in my practice, I do extrapolate this data to in-hospital cardiac arrest. And then what about the initial presenting rhythm? Does that matter? It makes sense physiologically for shockable rhythms to be more sensitive to harmful effects of epinephrine than non-shockable rhythms. And we'll look at that in a little bit. And then we also have potential situations where measures to combat post-resuscitation syndrome were employed, such as hypothermia or no hypothermia and PCI versus no PCI. And then lastly, what about extracorporeal CPR? And that's an option. But first, back to our focus on the initial presenting rhythm, as this physiologically makes sense. Shockable rhythms, epinephrine may be more harmful. Patients still have some heart activity, and beta-1 additional activity may just increase myocardial oxygenation demand and lower the threshold even more for arrhythmias. So the first trial I want to look at is from this 1998, this Behringer study. It was a retrospective study that included 178 patients with witnessed normothermic, out-of-hospital and in-hospital cardiac arrest, and initial VF presenting rhythm with unsuccessful defibrillation. They looked at cumulative epinephrine dosing in associations with outcomes. On the right here, on the top right, we have figure 1. And then on the y-axis, you have the number of patients, and on the x-axis, we have the cumulative epinephrine dose. The gray bars represent those that were able to achieve ROSC. So with increasing doses of epinephrine, even at doses on those far two right bars with 10 to 13 milligrams or 14 to 50 milligrams, there are relatively still pretty good rates of ROSC overall. But then when we look at cumulative epinephrine dosing and good neurological outcome on the graph on the bottom there, we can see same orientation here along with the cumulative epinephrine dosing along the x-axis. We see overall that the white bars increase. And so overall, there is a trend towards poor neurological outcome compared with good neurological outcome. So this study found that ROSC was possible even with increasing cumulative doses of epinephrine, but good functional outcome was less likely. In conclusion, they found that an increasing dose of cumulative epinephrine during ACLS was independently associated with favorable neurological function and after ventricular fibrillation cardiac arrest. In 1998, already from this study, there was a call for a dose limit, which may serve as a marker for terminating resuscitative effects because doses that exceed a specific amount may be associated with poor outcomes. And you can see here from the graphs on this slide, maybe it could be reasonable to cap at 3 to 5 milligram doses due to the large decrease in favorable neurological outcome. So this makes sense physiologically with shockable rhythms. I want to take a look at non-shockable rhythms now. So this is a 2012 retrospective study at the same site as the study before in Vienna, Austria. They included witness cardiac arrest patients, both in hospital and out of hospital cardiac arrest, and they presented with non-shockable rhythm. The study aimed to evaluate if cumulative epinephrine dosing was associated with in-hospital mortality and favorable functional status. And they categorized the epinephrine into 4 different quartiles. So on the table here in the results section, we have on the top a univariate analysis and the bottom a multivariate analysis, with the second column being in-hospital mortality and third, the unfavorable functional status. For this univariate analysis, the comparator was the first row here at 0 to 1 milligrams dosing. You can see that as we move along each one of the rows and goes down, with each dose increasing quartile, there was a statistically significant increased risk for both in-hospital mortality and unfavorable functional status. The authors also performed a multivariate analysis to control for many of these confounders listed here on the slide. And once again, the results were similar, with increasing doses of epinephrine directly and independently associated with increasing risk for unfavorable functional outcome in hospital mortality. So in conclusion, the authors concluded that increasing epinephrine dosing was associated with increased in-hospital mortality and unfavorable functional outcomes. But was that one study just a fluke? So I just want to, because this is non-shockable rhythms and a retrospective study. This was another 2023 retrospective study out of a different country in France, and they looked at out-of-hospital cardiac arrest patients. They once again divided epinephrine into 4 different categories, with none, 1 milligram, 2 to 5, and then greater than 5 milligrams. They also looked at specific different distribution modes of death, as you can see here in figure 3. So along the x-axis, once again, we have the total epinephrine dosing, and you can see that with increasing epinephrine dosing, this gray bar on the bottom is overall greater, and that is a cardiac circulatory death. And this is potentially thought to due to one of the epinephrine harms that we mentioned previously with post-resuscitation syndrome. The authors still also performed a multivariate analysis here to control for potential confounders. And once again, they found that with cardiocirculatory death in the first column here, with increasing doses of epinephrine, they found an increasing risk of cardiocirculatory death, as well as neurological death and other death. In conclusion, the authors found a strong, independent, and graded association between risk of early cardiocirculatory death and cumulative epinephrine doses with post-ROSC care. I think it was interesting that most survivors received cumulative epinephrine dosing of 3 or more milligrams or more versus less than around 3 milligrams. So maybe 3 milligrams, maybe that magical number, everything comes in threes, and that could be where epinephrine could be of diminishing return. So we've gone through studies with just potentially shockable rhythms and non-shockable. It seems that maybe 3 milligrams is the magical number. These next couple of slides, you determined to skip over them, but they were 2 studies that did include both shockable and non-shockable rhythms, and kind of found similar results as here in this 2019 Falter-Gill study. For their results, they looked at cumulative epinephrine dosing, and they found that greater than or equal to 3 epinephrine doses were associated with a decrease by about 85% hospital discharge survival and a decrease of 1-year survival by about 82%. So once again, spreading epinephrine was associated with decreasing odds of survival or any like meaningful neurological outcome. So overall, which situations versus situations that we mentioned before is epi potentially worsen? But basically all of them. But this does bring us to the last point about eCPR. Just want to briefly mention eCPR here, an extension of conventional CPR when standard therapy has proven ineffective by utilizing ECMO to provide appropriate perfusion and gas exchange, just kind of giving us time to address the underlying cause of cardiac arrest and preserve that neurological function. We've covered previously potential harms of epinephrine, but the two in red here are more specific to eCPR. So specifically for eCPR, we can have harms of technical challenges during vascular cannulation, and then the excessive systemic arterial afterload can also prohibit satisfactory ECMO flow. So ECMO may help preserve neurological functions, but we really need to consider this with our large doses of epinephrine. As we've seen previously, this can lead to impaired microvascular cerebral circulation and thus decreased neurological function. So we really just need to carefully consider how much epi to give in these patients. This was a retrospective study, 2024, that did evaluate cumulative epinephrine dosing in eCPR. So just answering that question that we were been answering previously. They defined a priori epinephrine dosing with low, less than or equal to 3 milligrams versus high, which they defined as greater than 3 milligrams. Their primary outcome was favorable functional status at discharge. And so you can see here on the right on their graph for the CPC or their cerebral performance category scale score, favorable outcomes were 56% in the low cohort versus 24%, so almost cut in half in the high cohort. Overall conclusions, cumulative epinephrine doses greater than 3 milligrams may be associated with unfavorable neurological outcomes after eCPR. And lastly, I just want to mention that epinephrine is here to stay. And so what are our thoughts on potential dose capping studies? Recall back all the way back to the study for 1998. We've gone through a lot of studies. They were already calling for potentially a dose cap in that 1998 studies. And overall, throughout these studies, it seems like maybe 3 milligrams or 4 milligrams might be a magical number. And so this was a 2022 paper that looked at US statewide ACLS protocols for non-traumatic out-of-hospital cardiac arrest between 2018 and 2021. And I like this because you can see like at least 63% of the protocols were available for the states, and then 5 states here recorded a change. So we have Arizona, Maryland, Rhode Island, Utah, and Vermont. Throughout these, the main change that you can see here in the 2021 changes in the results section, the most frequent change was a total epinephrine dose limitation of about 3 milligrams, except for Maryland, which was about 4 milligrams. So I think that we are kind of on potentially the quote unquote right path towards dose capping epinephrine. Also of note under Rhode Island there, the second consideration that they had was to quote unquote consider epinephrine infusion in place of bolus. So imagine like an epinephrine drip running at 0.33 mg per minute. And so this is kind of equivalent to the 1 milligram every 3 minutes for the ACLS dosing. Studies support this is currently lacking, but it does make sense with theoretical benefits. It simplifies the resuscitation process and produces a more consistent epinephrine level. And in the case of ROSC, the epi infusion is already available and you can just rapidly titrate it to avoid hypotension. Downsides, you do have to mix the drip before this at the beginning of the code, and that may take some delay in time. On average, it takes about 17 years for practice to change, but I hope that with knowledge from the CE, we can start these conversations sooner. And I think the changes in these states already may reflect the future direction of epinephrine in non-traumatic cardiac arrest. But until then, many sites like my own will continue to give unlimited epinephrine, just like in Oprah fashion, which may result in refractory ventricular fibrillation, refractory to many shocks, many amiodarone, and so what else can we do? I'm going to turn this over now to Lisa to help us evaluate available evidence for therapies for refractory ventricular fibrillation.
Thank you, Tina. I am going to talk about refractory ventricular fibrillation. So the first thing I love to do when I'm giving presentation is insert a case, because we know we always want to take this back to the patients that we're talking about. So TH is a 47-year-old male, came to the ER in cardiac arrest. EMS reports that CPR was in progress on their arrival. Initial rhythm was ventricular fibrillation. He's had 3 shocks at escalating energies, 300 milligrams of amiodarone, and a total of 3 milligrams of epinephrine. They've been resuscitating the patient for 20 minutes, and they want to know what is the next course of action. So if anybody wants to put in the chat what you would say as your next course of action, this is going to kind of use as a roadmap for us to talk through the rest of what we're going to talk about today in terms of refractory ventricular fibrillation. So any ideas about what you would do next for this patient who is in what we are going to term refractory VUHAC, and we'll talk about that terminology in just a second. I'll give everyone just a second. Somebody said dual sequence defib. Okay, I love it. Got a couple of votes for that. Esmolol. Okay. Y'all are giving away all my secrets here. More amiodarone, a stellate ganglion block, additional amia versus lidocaine, esmolol, dual defib, a ganglion block. Okay, perfect. Tina, you can flip, and that will give us kind of our roadblock for the next part of this. And so we're going to talk about many of the things that you all mentioned. So an amiodarone bolus, a lidocaine bolus, esmolol, procainamide, magnesium, question mark, double desequence defibrillation. Ooh, I'm going to struggle with that. And then perhaps, is it appropriate to terminate the resuscitation? So lots of questions there. So we can go ahead and go to the next slide. And so we're going to be talking about refractory ventricular arrhythmias today. So there's no formal definition in the literature. What it tends to be referred to as a continuous ventricular tachycardia or a ventricular fibrillation without return to a sinus rhythm. Typically, it's rapidly clustering episodes of ventricular fibrillation that are recurrent to or persistent after multiple defibrillation attempts without achieving ROSC. There's a lot of definitions used in the literature. The one that I used in the case previous is kind of what you can see sometimes, which is 3 defibrillation attempts, 3 milligrams of epinephrine, and 300 milligrams of amiodarone. There are a fair number of studies that also use the idea of 3 defibrillation attempts, and so you'll see that in the literature we talk about today. Kind of on the flip side to that, we're not going to spend a lot of time on ventricular storm today, but ventricular storm is 3 or more episodes requiring an intervention within 24 hours. So these are often the patients who are getting ROSC, but then perhaps flipping back into a ventricular arrhythmia. You can go ahead and flip this slide for me, Tina. So the ACLS algorithm, the AHA recommends a shock first strategy. So you can go ahead and click and we'll get some animations. And then they recommend epinephrine as their first medication. So we can click again. And then they recommend delaying antiarrhythmics until after the second shock. And so go ahead and flip, Tina, for me. So in the real world, what is your practice for refractory ventricular fibrillation? And so I think there's a lot of questions out there, and you all have brought up a lot of them and kind of the initial thought processes on what we would do for our case. You can flip one more time for me, Tina. So is there a maximum dose of epinephrine? So Tina brought up the idea of that. Should we withhold epinephrine? Should I stop giving it? Should I delay antiarrhythmics until after I've given epinephrine, or should antiarrhythmics be more first line? We'll talk about that today. And an age-old question, should I use amio or should I use lidocaine? So we'll answer some of these questions today. Some of them there's not a great answer for, but we'll kind of talk about what the literature is out there. So you can go ahead and flip this slide, Tina. So what is the role of epinephrine in our refractory ventricular fibrillations, or RVF patients? So Tina talked about the Behringer study from 1998. So basically they found that larger cumulative dose of epinephrine in patients with ventricular fibrillation had poorer neurologic outcomes. A more recent study that's come out is Fana and colleagues in 2025. And so this was a population-based propensity registry in Paris. And so they looked at out-of-hospital cardiac arrest. They used that definition of refractory ventricular fibrillation as 3 defibrillation attempts. And they enrolled about 3,000 patients, 2,500 of which got epinephrine and about 600 of which did not get epinephrine. And they wanted to look at, did they have a favorable neurological recovery? So you can flip this slide. And so that was their primary outcome. They used the CPC that Tina's referenced before. I kind of think of this as the modified Rankin scale for kind of the resuscitation world. And so what they found was that patients who received epinephrine had a favorable neurologic outcome 11% of the time, and those that received no epinephrine had a favorable neurologic outcome 50% of the time. And so they found that epinephrine use was negatively associated with a favorable neurologic outcome And that remained consistent even after their propensity score matching. They went even further and said, is there a dose kind of where that kind of falls out? So they compared 0.5 to 5, 5 to 8, and greater than 8 milligrams. And they kind of reiterated a lot of things that Tina's already mentioned today. As the dose escalates, you're likely to have a non-favorable outcome. So your likelihood of a favorable outcome goes down. There are some limitations to the study. When you look at the groups, there is more bystander CPR and more bystander defibrillation in your no epinephrine group. And we know that whenever I teach students, we think about the idea that there really is no medication that's beneficial in resuscitation. CPR is that answer. And so perhaps that is a limitation to this. So you can go ahead and flip to the next one. So what is the role of epinephrine in refractory ventricular fibrillation? The European guidelines say delay epi until after the third shock is delivered in your kind of shockable rhythms. And then, spoiler alert, the ACLS guidelines are supposed to be updated next month. So we'll see what we find out there. So kind of flip the slide. So perhaps the answer is less is more. Maybe epinephrine less is more is the answer. So we'll that's my answer for epinephrine. So probably less is more in the case of patients who have a shockable rhythm. So what are the other things that we can do? The age-old question of, should I use amio or should I use lidocaine? And so there are lots of studies out there. I tried to pull, obviously, what you all know as some of the landmark studies. So the ALIVE study that looked at amiodarone versus lidocaine in your out-of-hospital cardiac arrest patients looked for survival to ICU admission was more likely in their amiodarone group. No differences in rates of hospital discharge. Their takeaway is that amio was better than lidocaine. The ALP study in 2016, another study that looked at amio versus lidocaine versus placebo, multicenter, and they found that there was no difference in survival to hospital discharge, and there was no difference in the favorable neurologic outcomes. So they basically said, it's a wash. Amio, lidocaine, placebo, probably, we didn't find any difference. And then a more recent study by Wagner and colleagues in 2023, they used the Get With the Guidelines database and looked at amiodarone versus lidocaine. And they found that lidocaine had higher rates of ROSC, higher rates of survival, and higher rates of favorable neurologic outcomes in your lidocaine group after they adjusted for covariates. So again, the answer is, I'm not sure which antiarrhythmic is the best. And so the question becomes, maybe the timing of the antiarrhythmic is more important. So go ahead and flip to the next slide, and we'll talk about some of the studies that look at timing for antiarrhythmics. So there's a lot of words on the slide. Don't be kind of alarmed. By Lee and colleagues in 2019, it's a pretty small study, about 130 patients. But again, in the resuscitation literature, a fairly large amount compared to some of the other studies we may see. It was a retrospective analysis, previously collected prospective data. And so they took a data pool of about 11,000 and drilled it down to those 134 patients. They did a multivariate logistic regression to determine what the time frame of benefit was for amiodarone. So what they found was from the initial EMS call to the administration of amiodarone, if you could do that within 20 minutes, those patients had higher rates of pre-hospital ROSC, higher rates of survival at hospital arrival, higher rates of any kind of ROSC, higher rates of survival at admission, survival to discharge, as well as a favorable neurological outcome. And so they kind of have tied this idea of their study that amiodarone within 20 minutes of that EMS call, so basically from the initial resuscitation, if you're kind of doing CPR on scene, was an independent factor affecting neurological outcome at discharge. So then we come to WISA and colleagues. They are a little bit larger, about 500 patients. Again, out of hospital cardiac arrest, got amiodarone pre-hospital arrival, and they found similar findings. So what they found was it took about 25 minutes to give amiodarone to patients, and the kind of time frame that was associated with positive effects from amiodarone was 23 minutes. So if a patient got amiodarone within 23 minutes from the EMS call to administration of the amiodarone, that they had an increased chance of surviving the event, as well as an increased rate of discharge survival and 30-day survival. They did caveat in their study, there's lots of things that factor into this. So how quickly the paramedics are able to access a patient and what the time to IV access is as well. And then the last one, largest one that we'll talk about in terms of timing for antiarrhythmics is Lupton and colleagues, and they have about 2,800 patients. They actually did a secondary analysis of some other data that had already been collected, and they stratified this by amiodarone, lidocaine, and placebo. And then 8 minutes, so within 8 minutes or after 8 minutes. And what they found was that amiodarone given before 8 minutes was associated with improved survival to admission, survival to discharge, and functional survival compared to placebo. They didn't find any difference for lidocaine. So again, the questions are, I don't know, is lidocaine better, is amiodarone better? But from the literature, it probably says that timing may be more important here. And then we'll flip the slide and we'll talk about in-hospital cardiac arrest. So this is a very recent study that came out in 2025. They have a fairly low number of patients, 88 patients, but it was a retrospective multi-center observation cohort for about 10 years. And they found that early administration of amiodarone or lidocaine prior to the second defibrillator shock increased your odds of achieving ROSC as well as kind of surviving to hospital discharge when you had a ventricular arrhythmia. And they did kind of give this odds ratio in terms of the likelihood for ROSC for each minute of delay of amiodarone and lidocaine. So that's also something to think about. So we have the guidelines from the AHA that basically say you should kind of wait to give, you should epinephrine first and then give antiarrhythmics. And maybe that's not the answer. Maybe early antiarrhythmics is probably a better solution. And maybe when we've talked about all the issues with epinephrine, particularly in our shockable rhythms, that we may be needing to reach for this first. Go ahead and flip the slide for me. Magnesium is kind of a catch-all, right? We use it for lots of different things. And so there was some kind of push a few years ago to kind of consider magnesium in our ventricular fibrillation patients. Pulled a couple of older studies, 2001 and 2002. They both looked at magnesium in their patients with refractory ventricular fibrillation defined as 3 shocks. Neither of them found any difference. So I would say probably magnesium is out, so you can flip the slide. I probably wouldn't use magnesium in my toolbox for ventricular fibrillation and outside of the idea of if patient has a true torsades. So we can go ahead and keep going. And so that brings us to a good question. A lot of you brought up esmolol earlier. So what is the role of beta blockade in our refractory ventricular fibrillation patients? And so Tina has talked a lot about all of the kind of risks and benefits of epinephrine. So patients in cardiac arrest have high levels of catecholamines, both endogenous and exogenous, and we're giving them more with epinephrine. We know that there's a benefit from epinephrine, constriction, increased coronary perfusion pressure, but we know that comes with a risk as well. And so that activates our beta-1 and beta-2 receptors, that increases our myocardial oxygen demand, can worsen our ischemic injury, as well as lower our ventricular fibrillation threshold. So the idea of beta blockade came about when perhaps we need to get rid of this, kind of block beta to be able to kind of overcome the refractory ventricular kind of negative feedback loop that we think about. So you go ahead and flip to the next slide. A little history of that. I love a good history thought process when we think about something. So in the early 1980s, 1990s, ventricular fibrillation was reported in about 40 to 60% of our out-of-hospital cardiac arrests. Compare that to the late 2000s, kind of that's the middle of the arrow that you're looking at. Ventricular fibrillation has actually decreased and is only reported in about 1 out of 4 out-of-hospital cardiac arrests. So how did we get there? In 1999, Exner and colleagues kind of looked at a study that showed beta blocker use was independently associated with improved survival in patients with ventricular fibrillation. Nemandi and colleagues in 2000, they compare a sympathetic blockade, so either propranolol or esmolol, in their patients with electrical storm. So these patients did not actually have cardiac arrest, but they were looking at those patients with the ventricular storm, kind of the other kind of caveat that we talked about earlier, and they found that sympathetic blockade was beneficial. Huang and colleagues in 2004, they actually looked at rats. So this is a rat study compared to like where we had dog studies earlier. So rat study where we had propranolol given to rats improved their post-resuscitation survival. So that beta blockade may actually be beneficial. An interesting study by Youngquist and colleagues in 2008, and they postulate that the increased use of beta blockers, so beta blockers for lots of different disease states, may be the reason that we're seeing less ventricular fibrillation and out-of-hospital cardiac arrest. So those patients already have beta blockade on board, and that may be a reason that they're not ending up in ventricular fibrillation as the cause of their cardiac arrest, or the rhythm associated with their cardiac arrest. So that brings us to kind of a landmark study, which is in 2014, Driver and colleagues published about esmolol for refractory ventricular fibrillation. So you can flip the slide. So we'll talk about esmolol in terms of the different studies that are out there. So that initial one, and kind of the one that kind of, I would say, made esmolol popular in 2014 was Driver and colleagues. It's a single center retrospective cohort. They gave 500 mics per kilo of esmolol, and then they either started a drip or didn't start a drip, somewhere between 0 to 100 mics per kilo per minute. Really small study, only 6 patients. And so their population was 55 generally, middle-aged males, 92% were initially in the ventricular fibrillation, 77% had bystander CPR, and esmolol was administered after a median of 6 shocks and a cardiac duration of 44 minutes. The esmolol group had higher rates of ROSC, higher rates of survival to the ICU, as well as higher rates of survival to hospital discharge with a good neurological outcome. So 50% of patients versus 11% of patients. So kind of a lot of questions, a lot of kind of thought generating came from that. And then we have the additional 3 studies that we'll look at today, kind of, as you can see, escalating in size. So Lee and colleagues in 2016, another single center retrospective cohort gave an esmolol bolus and then esmolol infusion, 25 patients, again, middle-aged male. About 2/3 had initially ventricular fibrillation and about 2/3 had bystander CPR. The esmolol group had higher rates of ROSC after 20 minutes, higher rates of survival to the ICU, and higher rates of good neurological outcome at 30 days. Still not great, right? 19% versus 8%, but it is something that was kind of out there. They didn't necessarily have a statistically different finding there, but they did have more patients with a positive neurological outcome at discharge. Leanne and colleagues, a multi-center retrospective case series in China. Again, no comparator in this group, it's just a case series, but they did the esmolol bolus and then esmolol infusion. This was in hospital cardiac arrest, and they had, again, kind of middle-aged male, median of 9 shock attempts, 6 attempts before the esmolol. And so the esmolol group had higher rates of ROSC and as well as higher rates of overall survival. But again, remember there's no comparator in this one. And then the largest one that I was able to find today, Patrick and colleagues published in 2022, they had 133 patients. And this was actually a study in pre-hospital setting. So they were added esmolol to their EMS algorithm. And so from 2017 to 2020, they did a kind of pre-post. And so they gave an esmolol bolus with no infusion. And so they had 70 patients in their intervention group. And then they had, again, mostly middle-aged males, a fair amount of bystander CPR, and a fair amount of people who were initially in ventricular fibrillation. The esmolol group had higher rates of pre-hospital ROSC, but the survival at 24 hours and survival to hospital discharge were similar in the pre-post study. So the esmolol, no esmolol. So lots of questions here, but I would say that we can flip to the slide there, Tina. I would say sympathetic blockade with esmolol may improve outcomes. It's not a 100%, but it's something that's definitely in my toolbox that I'm going to think about doing. So how am I going to actually implement that in my toolbox? So esmolol, remember, it's a non-selective IV beta blocker, has a short half-life, about 9 minutes. Allows you to terminate therapy if things go awry. In case you have something that, the patient ends up in cardiogenic shock, it's that fast on, fast off. The dosing and kind of iterated in the studies that we looked at previously, usually a bolus dose, 500 mics per kilo, and then considering an infusion anywhere from 0 to 100 mics per kilo per minute. Logistics here are complicated, right? And so it's likely not in your crash cart, so it may not be readily available to you. We have put esmolol in our automated dispensing cabinet, so we have it available in that way. The math can be complicated because there's micrograms and milligrams, and some of the vials come in milligrams and some of them come in micrograms. And when you're stressed, sometimes that's hard. So thinking about how would you simplify that for you in the actual terminology when you would do it? Another thing that we have actually found recently is that we have built a bolus on our infusion pumps. And so we are actually able to use the bolus feature from our infusion pumps during a cardiac arrest. So if you set the esmolol up on the pump, you can give that 500 mic per kilo bolus on the infusion pump, and then you can start a drip if you want to, instead of having to deal with the vial and drawing up that or drawing up a bolus from the bag. And so we are actually able to do that with our Alaris pumps. And then you can flip, Tina. Probably you should not stop using epinephrine. If you've still been using epinephrine and you're deciding to do esmolol, I usually make my doctors decide, do you want more epinephrine or do you want esmolol? And so probably if we're trying to beta blockade, we shouldn't give more beta agonists. And so that's something to think about. You can flip to the next slide. So this is an interesting thing that's up and coming. There's not a lot of data from this yet, but it's a mixed methods project called Revive, and it's a national survey of pre-hospital emergency patients, emergency care services, our EMS services essentially, to look at the current landscape. So they're just kind of figuring out what people are doing, and then they're going to do a retrospective observational review of a national database, I assume with the Guidelines database. And then they're going to do some pilot studies to figure out what's kind of reasonable, but they're going to prioritize esmolol and de-emphasize adrenaline or epinephrine for out-of-hospital cardiac arrest. So some interesting things that may come from this to give us more data about esmolol. A question that I ran into when I had just finished residency, I maybe had been out maybe 6 months and I was doing this case, and a patient came in and they had refractory ventricular fibrillation, and that we knew they had WPW. They had gone into arrest in the back of the ambulance. The patient had told the EMS providers that they had WPW. So what should you do in those cases? Because those patients may be more likely to have a refractory ventricular fibrillation. Esmolol is probably not the choice for your patients, and you all can disagree with me in terms of WPW. The literature is not broad out there. We don't have a lot of information. Procainamide generally are a drug of choice for patients with WPW. The slower infusion rates make it logistically difficult. I did not find any literature about IV pushing procainamide, and so if you all find that, and you please send it to me, I would love to see it. And so Hubinger and colleagues, they had 51 patients who got procainamide, had higher rates of pre-hospital ROSC, but similar rates of ED ROSC and survival. And that wasn't necessarily in WPW patients, but procainamide is kind of out there, and that might be something to consider as well. And then lidocaine versus amiodarone, back to that old question. Amiodarone's controversial in your WPW patients, so I probably would reach for lidocaine. However, I might actually do something different, which is I might think about Edison versus medicine. And so you can flip to the next slide. I might be considering dual sequence defib for these patients. And that's actually what we did for this patient, and he walked out of the hospital like a week later, which was great. And so dual sequence defib, 2 defibrillators, simultaneous or near simultaneous shocks. You do run the risk of damaging your defibrillators, or a vector change defibrillation. So 1 defibrillator, you switch the positions of the pads. So you can kind of see this picture here. Some people also do 1 pad on the front and 1 pad on the back, depending on the size of your patient. Why are we doing this? The thought process is if you change the vector of energy, you may shock different areas of the heart that are resistant to that initial defibrillation attempt. You can flip the slide. So DOSE-VF came out in 2022, compared standard defibrillation to DSD to vector change in your patients with refractory ventricular fibrillation. That was defined as 3 shocks, I believe. It was a cluster randomized controlled trial, had crossover 6 EMS services in Ontario, Canada. They looked at survival to hospital discharge, had about 400 patients. Again, middle-aged males generally were their population, and about half, a little more than half, got bystander CPR. So you can flip to the next slide. This image is kind of the findings from that. And what you'll see is we have standard defibrillation. It's kind of in the blue, double sequence in the gray, and vector change in the black. And so what you can see is survival to hospital discharge, ROSC, termination of ventricular fibrillation, as well as our good neurological outcome. For the most part, double sequence defib has a better kind of outcome in all of these different situations. Not all of these were statistically significant findings, but it is definitely something that's low risk, high reward, I would say, is using double sequence defib. And so something to consider. You can go ahead, yeah, double sequence defib associated with better outcomes in all the categories that were evaluated. So we'll truck along here. So Edison, maybe it's better than the medicine. And so that's something to think about. I labeled this non-pharmacologic therapies, and then I thought later on, a stellate ganning block is technically a pharmacologic therapy. So sorry for the mislabeling there. The ARREST trial, early ECMO, that may improve survival to hospital discharge, but again, not something that's available to everyone. It's not a resource that all of us have available to us. And then many of you mentioned a ganglion block earlier. And so a local anesthetic injection is placed into the stellate ganglion, which is responsible for cardiac sympathetic innervation. So essentially you're kind of breaking that cycle. And so some people would lump this into an esmolol type therapy. And so you're trying to kind of break that kind of issue you have with that reciprocal things that are happening with our ventricular arrhythmias. And there is emerging literature for this in both in-hospital cardiac arrest and out-of-hospital cardiac arrest. And so there's this group that's put together. It's the STAR group, so stellate ganglion block for arrhythmic storm. You can flip to the next slide. And so that's something to also consider. So we're back to our case. And so this patient who's in refractory VFib, just kind of, you can go ahead and put stuff up there on the screen, Tina. And so amiodarone bolus, maybe. Timing might be more important though. Lidocaine bolus, maybe. Again, timing. Esmolol bolus, probably. Procainamide bolus, not sure. Literature's not wildly there. Magnesium bolus, probably not. Double sequence defib, I would probably put it in my repertoire. And then lastly, terminate resuscitation. That's definitely an option, but we also can consider stopping epinephrine boluses. And so you can flip, Tina, I think that's the last thing. So those are things that I would consider. Take-home messages, epinephrine, probably less is more. Antiarrhythmics, probably early is better, but I don't have an answer on which one you should use. Sympathetic blockade, either with esmolol or perhaps a stellate ganglion block, could be considered or should be considered if you have the ability to do that. And then again, Edison might be better than the medicine. And then I think we have a couple of assessment questions for you. I can't remember, am I supposed to read these or is somebody else too? Okay, I'll keep going. So, assessment question, which of the following statements is incorrect? An origin of epinephrine 1 milligram dosing appears to be stemmed from, trying to get all my boxes out of the way here, from animal studies, or increased epinephrine doses associated with improved outcomes such as survival. Studies have associated more frequent dosing, less than 3 minutes, with decreased survival at 30 days, or when converted to weight-based dosing, epinephrine dose recommended for humans is less than originally used for the animal studies. I'm seeing lots of B's. Tina, do you want to talk about the answer why this is the answer? You lost your slides.
Okay, sorry. Yeah, I just didn't know how to unmute without
You're
losing
good.
the slides. Anyways, now everything's gone. But yeah, so we talked about which statement's incorrect. The origin of epinephrine did come from the 1 milligram dosing studies all the way back from 1963. Let me see, how do I display the slides again?
There we go.
And then
Perfect.
increased epinephrine doses are associated with improved outcomes such as survival with favorable neurological outcome. We know that this is actually quite the opposite and may have impaired neurological outcome, but increased rates of ROSC. And then more frequent dosing is kind of like giving more epi. And so this is associated with potentially associated with decreased survival at 30 days. And then when converted to weight-based dosing, the epinephrine dose recommended for humans studies is really less than what was originally used for animal studies. And then question 2, which of the following below include proposed potential harms from epinephrine administration during cardiac arrest? Correct, all the above. We can have all of those and more as listed on the slides previously. There's just numerous potential harms from epinephrine during cardiac arrest.
And then this is my question. So select the most accurate statement from the following regarding refractory ventricular fibrillation. Patients with RVF should continue to receive epinephrine with no max dose. There's no impact on the timing of antiarrhythmic drugs on outcomes in RVF. Esmolol should be considered as it has been shown to increase rates of survival with favorable neurological outcomes, or dual sequence defib should be used immediately on identifying ventricular fibrillation. And then I'm seeing lots of C's. I didn't do a good job explaining it kind of during the session. I was kind of caught up on time, but most of the literature for dose VF, they did the dual sequence defib after 3 standard defib shocks. And so there's not any literature to say that you should be immediately using dual sequence defib like on an initial presentation. So those are our 3 assessment questions. I know there are a couple of questions in the chat, and I will let Liz moderate that.
Yeah, it looks like I see 2 questions so far. So the first one we have here is for Tina. How do you interpret the studies you presented on cumulative epi doses greater than 3 milligrams, leading to a non-favorable outcome because of the epi dose versus the fact if you have a larger cumulative dose, this means a longer downtime anyways? So is it really the drug?
Yeah, so a lot of the studies I mentioned, I didn't have time to go in depth, but majority of them did try to account for it, like by doing statistical, I call it gymnastics, by doing propensity score matching or multivariate analyses. And they tried to control for it in this way by doing the statistical analysis. But I think in the end, we can't adjust for those confounders. As more time equals more epi, you can't really adjust for those, like really tease them out, even with these like statistical analyses. I think the only study that didn't adjust for this potentially was with the ECMO study and this ECPR. And so when they compared the less than 3 milligrams or greater than 3 milligrams, they were not able to account for time because the populations were so small in those studies. But I think that's always going to be like a caveat when we're looking at like how much epi is like too much epi. Really, it's just maybe it's a time cutoff instead of the epinephrine that we're giving.
Thank you for that. And then the last one looks like it's going to be for Lisa from Kevin. Do you think it's right to reach for esmolol prior to the second dose of an antiarrhythmic, especially when there is significantly better evidence for providing antiarrhythmic over beta blockade, or do you wait until after the second dose of antiarrhythmic in real practice? It's kind of
Yeah,
a two-parter, so I'll stop there.
Yeah, I think that's an interesting question. I would say logistically, personally, I'm always going to reach for an antiarrhythmic because I have it in the crash cart and it's available. I would say if you have some, ability to kind of expedite, or maybe someone's on board with putting something like that in your crash cart, perhaps it might be appropriate to think about beta blockade earlier on. But in my personal practice, I would say I am going to wait until after the second dose of the antiarrhythmic to consider esmolol, just from a logistical standpoint.
And then this is just kind of a second part to that question. Do you have any other personal or internal selection criteria for when esmolol might actually be beneficial for these patients?
Also, a very interesting question. Anecdotally, I have seen it be most beneficial in patients who had some sort of STEMI and needed to go to the cath lab. And so, patients who had a reversible cause, that was the reason that they were in ventricular fibrillation. And so, that's personally, if I have a high suspicion for that, it's probably something that I'm going to recommend. But that's when I've seen it be most successful in those patients who needed to go to the cath lab.
All right, we got one last question that just squeezed in. I think we should be able to squeeze this in. It might be outside of the scope of this talk, but curious from your research as well as experience, what has been the go-to post-ROSC pressor in your institutions?
I can answer and then I'll let Tina answer, but we added Levophed or norepinephrine to our crash carts. And so that's because it's easier. We can get a pre-packed product for that. And so across the hospital, we tend to use norepinephrine as our initial pressor post ROSC, unless we think we need the kind of epinephrine from a bradycardic standpoint. But we've made it logistically to where people have a norepinephrine in the crash carts and more readily available.
Yeah, same here. We also have norepinephrine in the crash carts, and then we have our premix in the Omnicells. But from the crash cart, we can mix bedside epi or Levophed drips. But I prefer norepinephrine just because of the lower lactic acidosis and stuff. Mark shouted out to great year in review for AMP on that topic at this recent past year in 2025. Of that note, shameless plug for submit your year in review submissions by Thursday. Thanks, guys.
All right, I think that's all the time we're going to have. I just have some housekeeping things to go over. So thank you so much again, Lisa and Tina, for presenting this webinar today on a really important topic that seems to be an everyday topic. And thank you everyone who was able to join us today. As I mentioned before, a recording of today's webinar will be posted on the webinar page of SAEM for future viewing. AMP members will receive an email by the end of the week with information about completing the evaluation and claiming CPE credit. And we look forward to seeing you at a future SAEM webinar educational activity. Thank you again, and I hope everybody has a great rest of the day.
Thanks, everyone.
Thanks, everyone.